This is Maria Derisic. I'm happy to share some details of a project our team has been working on behalf of my co-authors listed here. It's titled Variability in Surgeon Decision-Making, Postoperative Immobilization and Therapy After Hip Surgery in Children with Cerebral Palsy. The background to this project really is that there is no standard protocol for the management of progressive hip displacement in children with CP. And as a result, there's quite a bit of variability across the surgical preferences and recommendations of different surgeons. For example, reconstructive hip surgery can be performed in either a bilateral or unilateral procedures. There are also different postoperative immobilization techniques selected, as well as recommendations for postoperative mobility restrictions and range of motion, as well as the inclusion of physiotherapy in the postoperative care, which is often poorly described and really lacks information regarding the timing of it, the settings of it, and how often it should take place. For those of you who may be less familiar with the kinds of surgical procedures we're referring to, this diagram here in picture A, it presents really hip displacement. Picture B describes a varus rotation osteotomy, or VDRO. This is when an osteotomy is performed in the proximal femur and a wedge of bone is removed. That allows the proximal portion of the femur to be tipped towards the acetabulum to be more congruent with the other side of the joint. The distal part of the femur is then rotated externally. Picture C depicts pelvic osteotomy, and that's when that wedge of bone that was removed from the VDRO can then be inserted into the pelvis through an osteotomy to allow the acetabulum to be deepened and to provide greater coverage of the acetabulum over the femoral head. The radiographs on the right show how this can all be performed either in a unilateral procedure or in bilateral procedures. So the purpose of this project was to investigate the trend among orthopedic surgeons in what is really an ongoing debate between the use of unilateral versus bilateral reconstruction for unilateral hip displacement, and to explore the differences in surgical decision-making, as well as the variability in postoperative recommendations regarding weight bearing, immobilization, and recommendations for physiotherapy. At the same time, we were hoping to gain some information of what current practice models might be used in the perioperative management of hip displacement. So 44 orthopedic surgeons with known pediatric practices were approached to participate in an online survey. Questions in the survey included information about demographics and practice setting, but really focused on a series of case studies. The primary one was that of an 8-year-old male with CP at GMSES level 4, with migration percentage on the right hip of 76% and on the left of 22%. Surgeons were provided this radiograph and asked to select from this the following list of surgical options what they would recommend be performed based on the radiograph. Options included a right varus rotation osteotomy, or VDRO, a right VDRO with a right pelvic osteotomy, bilateral VDROs with a right pelvic osteotomy, or bilateral VDROs with bilateral pelvic osteotomies. Surgeons were then asked in an open-ended question to provide a reason for their surgical recommendation. In total, 28 orthopedic surgeons from 9 countries, with a mean of just over 21 years of experience, completed the survey, all identified following some kind of standardized hip surveillance guideline. Additional team members were also identified that might be included in the preoperative consultation or surgical decision-making. The most frequently identified team member was a physiotherapist, included by 19 of the 28 surgeons. Occupational therapists were also identified by 8 of the 28 surgeons. The inclusion of other team members throughout the rest of the perioperative process was also investigated. When it came to physiotherapists, 79% of surgeons identified that they were included in the immediate postoperative period. 82% stated that they were involved in a patient's discharge planning after surgery, and 79% stated that they were included in the postoperative orthopedic follow-up period. For occupational therapists, 32% of surgeons stated that OTs were involved in the immediate postoperative period. 46% in the discharge planning period, and 39% stated that they were part of the ongoing orthopedic follow-up. So when it came to the recommendations of what surgery would be performed, 32% of the surgeons who responded stated that they would choose to perform only a unilateral procedure. That would include a right VDRO and a right pelvic osteotomy. 68% of surgeons stated they would perform bilateral VDROs and a right pelvic osteotomy. The reasons given for those who chose a unilateral procedure stated that this was because the left hip looked like there was a low risk for displacement, that the left hip looked sufficiently covered, which was stated as the reason by 89% of those who chose this unilateral procedure, that the migration percentage of the left hip was less than 30%, and that there was a well-developed acetabulum. For those that chose a bilateral procedure, 84% of respondents stated that this was chosen to restore symmetry, to decrease the chance of dislocation or subluxation of the contralateral hip. And others identified wanting to avoid windswept deformity. In terms of the types of immobilization typically reported to be used by surgeons, the most common option reported was that of an abduction wedge pillow with bilateral knee immobilizers, such as the Zimmers featured here in picture 1. This was the option identified by 9 or 32% of the responding surgeons. The second most common was just the use of an abduction wedge pillow, selected by 29% of surgeons. The fourth most common immobilization technique was a hip spica cast, and this was stated by only 2 of the surgeons. Now, I'll point out that this is, of course, the fourth option that was listed, and that's because the third most common option was to have no immobilization at all. Surgeons also identified the frequency or how often this would be used and whether it could be removed at times for such as transportation. You can see that a smaller portion of surgeons stated that the immobilization needed to be on full time, and then it could, for a small number of surgeons, also be considered to be removed for transportation. With regards to postoperative restrictions, 50% of surgeons stated that they would likely have patients begin to mobilize to wheelchair by approximately post-op day 2 or 3. Range of motion was restricted in hip flexion by 25% of surgeons and in hip adduction by 40% of surgeons. The range of hip flexion that was stated would be restricted ranged from restriction to between 30 to 90 degrees. For hip adduction, this ranged from 0 to 40 degrees. The duration in which these restrictions were applied also varied, and this was a range of between weeks 0 to 12 weeks post-op. With regards to restrictions for weight bearing, most surgeons indicated that patients would return to full weight bearing at approximately 6 to 7 weeks post-op. There was a range in stated responses for when patients might be able to begin partial weight bearing, and this varied between starting at 0 to 6 weeks post-op. For full weight bearing to start, this ranged among surgeons from 0 to 12 weeks post-op, and the duration in which this weight bearing restriction would be applied also varied anywhere from 0 to 12 weeks post-op. Regarding recommendations for physical therapy, 18 of the surgeons, or 64% of respondents, recommended that PT be involved in care immediately post-op, and 2 surgeons stated that this would sometimes be recommended. Of these 18 surgeons, however, or rather 20 surgeons, only 12 of them reported that 100% of patients would therefore receive a physiotherapy immediately postoperatively. 27% of surgeons, or 96%, recommended physical therapy for goals such as range of motion, strengthening, and returning to baseline function. Of those 27, however, only 13 reported that 100% of patients would receive physiotherapy for these goals. 11 recommended that physical therapy start within 1 week of surgery, though the range of this recommendation varied among surgeons between 0 and 16 weeks post-op. 14 of those 27 surgeons recommended that physiotherapy take place 2 to 3 times per week, though there was a range across surgeons of frequency from rarely to daily planned physical therapy. 21 of surgeons, or 75%, reported that there was inpatient rehabilitation available for patients who might need it. 18 of those 21 only 18 of those 21 reported that only up to 25% of patients accessed that inpatient rehabilitation. Only 2 reported that 76 to 99% of patients would access that inpatient rehabilitation. When asked about the location in which rehab would take place for patients, surgeons identified, and this was within the immediate 6-month post-op period, 16 surgeons stated that this would likely happen in an outpatient rehab facility. 11 reported that it would take place in the patient's own home, 11 at school, and 6 in an inpatient rehab facility. So clearly, there was a divide among the orthopedic surgeons surveyed with regards to their recommendations for treating a unilateral hip displacement between a unilateral and a bilateral procedure. A greater understanding of the long-term outcomes of either of these surgical approaches is certainly needed to guide practice for surgeons. Recommendations for postoperative immobilization and therapy were found to be highly variable across surgeons. And the access to rehabilitation also was variable, though the outcomes of this survey suggest that this may not entirely be related to the availability of that rehabilitation, as surgical practice preference may also be a factor. So in conclusion, one thing that we can perhaps consider as we evaluate research and projects going forward is that it's possible that in any multi-center prospective investigation of surgical outcomes, the surgeon decision-making may in fact be the most significant variable to consider. In terms of next steps, there is the CP Hip Outcomes Project, or CHOP, which is a multi-center international prospective study on the outcomes of different interventions for hip displacement, is ongoing and centered out of Toronto. And hopefully that will provide some additional long-term data eventually on the outcome of these types of surgical interventions. However, future research is certainly needed on the perioperative care with respect to rehab, and that this research really would benefit from inclusion of families in that process to learn more about what is most meaning and best tolerated by families, as well as PT and OT. So thank you for listening, and I'd like to acknowledge the contributions of Jamie Coates, Keely Matthews, and Judy So in this project. Thanks for listening.